Well, thank you, everyone. So, on behalf of the COBRE on opioids and overdose at Rhode Island Hospital, the West Virginia Clinical and Translational Science Institute, the West Virginia IDEA Network of Biomedical Research Excellence, the Center for Addiction and Disease Risk Exacerbation at Brown University, and my own Rural Drug Addiction Research Center at the University of Nebraska. Welcome to the 2024 Symposium on Substance Use. My name is Nick Hubbard, and I have the distinct pleasure today of introducing our incredible speaker as well as moderating the discussion session that will follow. A few housekeeping items before we begin. This session is being recorded, and all registrants will receive access instructions to these resources via email, and these will be posted on our website. Also, since this is a webinar, this means that attendees' microphones will be muted. However, to help facilitate a lively discussion, please post your questions in using the Q&A function. We'll respond to these at the end of the talk. With those housekeeping items out of the way, I am honored to introduce today's keynote speaker, Dr. Diana Martinez. Dr. Martinez is a psychiatrist and neuroscientist at Columbia University's Irving Medical College, where she holds a professorship in the Department of Psychiatry. Much of Dr. Martinez's work has been at the forefront of neuroimaging and neuromodulation to use these to understand and importantly intervene in the addiction cycle. Her current research focuses on implementing neuromodulation therapies in substance-using populations, including leveraging cutting-edge approaches such as transcranial magnetic stimulation, as well as peripheral nerve blocks. So thank you for joining us today, Dr. Martinez. I will turn it over to you for your talk.
Great, thank you. Thank you for having me. I'm really quite happy to be here. So today I'm going to be talking about the neurocircuitry of habit and change and how this applies to substance use disorders. And I'm going to use neuroscience as a framework for talking about treatments for addiction. So let's start with some data with respect specifically to access to care in substance use disorders. So the first thing that's important to realize when we're talking about the treatment of addiction or substance use disorder is that it's effective. Treatment can improve quality of life, it reduces fatality, and improves health disparities. And in fact, when we treat substance use disorders, we have recurrence rates that are similar. So the efficacy is similar to treating diabetes, asthma, or hypertension. Of course, the problem is that most people don't have access to care when it comes to substance use disorders. And we know that millions of Americans struggle with a substance use disorder, and we have only 3,000 physicians in this country with specific advanced training for substance use disorders. That means 3,000 physicians who are trained as either addiction psychiatrists or in addiction medicine. And that's just obviously simply not enough to treat all the people that need care. But the truth is most individuals who are dealing with an addiction don't specifically need an addiction psychiatrist or someone who's certified in addiction medicine. It's as if everyone we saw with diabetes needed to see an endocrinologist. Many times diabetes can be managed by healthcare providers that aren't necessarily endocrinologists, and the same applies to substance use disorders. Many patients can get better with treatment delivered by healthcare providers. And so what I'm going to talk about in this seminar is how can we provide resources for providers who want to do more to treat substance use disorders. And I'm going to use, as I mentioned, the neuroscience of habit and change to explain how treatment works when it comes to addiction. So I'm going to start with just a little bit of neuroscience here. Mostly I want to talk to begin with about habits. Habits sort of define most of what we do in the world. Some of them are good, some of them are bad, some of them are neutral. And, the brain really operates on habitual behavior. Habitual behavior is what lets us sort of devote these amount of resources to thinking, whereas we can, sort of let our brains activate or use cognitive resources to develop solutions for neurocomplex situations. But habits can also get in the way. And this is what we see with addiction is habitual behavior tends to make people repeat the same pattern, even though there's a need to adapt and change those behaviors. So if we look at the brain, habitual behavior is often driven by the striatum, sort of centered here in the middle of the brain. We have the caudate putamen. And some of the drivers of habitual substance use or substance taking in addiction are craving, intoxication, withdrawal, and stress. So the question is, how can we change this? And one way to change habits is by enacting or activating cognitive control, which sits within the prefrontal cortex. So I'm going to talk about today is how pharmacotherapy or how treatments can reduce these factors that drive habitual behavior, like craving, intoxication, withdrawal, and stress. Psychotherapy can also have an impact, and so can neuroplasticity. So I'm just going to start with a definition of substance use disorder. I know this is familiar to many of you, but I'm just going to go over this quickly. We can divide the criteria. There are 11 of these to diagnose a substance use disorder into 4 broad groups, beginning with impaired control over use. So the symptoms of impaired control over use are taking more of a substance or more of a drug than was intended for longer periods of time. A persistent desire to cut down or decrease use that is often unsuccessful, spending a lot of time obtaining the drug or recovering from its effects, and craving. Then we have the social impairment category, and this is largely defined by people not meeting their obligations. This can be work, home, or school. It can be drug use that interferes with interpersonal relationships, or it can be drug use that interferes with recreational activities or passions like playing soccer or dance or painting. Then we have risky use. This is the use of substances in unsafe environments and the use of substances or drugs that continue despite physical or psychological problems. And then we have the pharmacological effects. This is tolerance, where a person needs more and more drug in order to get the same effect, or the usual dose has a reduced effect. And then we have withdrawal symptoms, and these are uncomfortable symptoms that are precipitated by with stopping the drug use or decreasing its use. And when we're diagnosing a substance use disorder, it's important to remember that mild substance use disorder is diagnosed when people have any 2 or 3 of these symptoms, moderate as 4 to 5, and severe as 6 or more. But I just want to point out that, every severe substance use disorder begins with moderate to mild. And so when we're talking about substance use disorders, it's going to be very important to do more to diagnose and treat mild substance use disorders, because this is going to be a more treatable situation. It's just like treating diabetes. We no longer wait until diabetes is a raging disorder. We now really try and act in the pre-diabetic stage or when it's mild, and we need to be doing this more with substance use disorders. I want to talk a little bit about the health problems with tolerance and withdrawal. Often when we think about health problems with addiction or substance use disorder, we tend to think of profound ones such as emphysema or liver failure. But the health problems can be more mild than that, and it's important to remember this. So the health problems can be things like insomnia. Both tobacco smoking and alcohol can cause persistent insomnia, and insomnia definitely has profound effects on health. It can also include headaches, stomach aches, weight loss, and these are seen with cannabis, nicotine, and alcohol. And when it comes to tolerance, it's important to phrase this question the way that patients often understand it. For example, I often ask patients, are you spending more money than before? Because people often pay attention to how much money they're spending on a substance. Anyone who's using a substance daily or near daily is probably almost certainly has tolerance, because it's very difficult to use a drug this frequently and not have tolerance. And then it's very common for people to take a drug break, where they will reduce or stop their use for a period of time so they can reduce their own tolerance. However, it's important to realize that when people do take a drug break, for example, if they decrease their cannabis use, they often substitute something else like alcohol during that time. And then similarly, withdrawal symptoms, often when I talk about withdrawal, we think of movies and people who are retching and sweating and can't get off the floor. But withdrawal symptoms can be very mild and can be very subtle, and people often don't think of them. And they can be as subtle as things like irritability, fatigue, headache, stomachache, restlessness. And it can be hard to know if you're experiencing withdrawal unless the person feels better when they take the drug again. And when it comes to diagnosing or screening for substance use disorders, I'll refer you to the SBIRT website. This is here on SAMHSA. It has a number of screening tools that can be downloaded for free. These are questionnaires and checklists that can be used to diagnose anywhere from a mild to moderate or severe substance use disorder. Now I'm going to start with tobacco use disorder. And the main reason I start with tobacco use disorder is that tobacco use disorder or smoking is still one of the most prevalent and common health problems that we see in this country. And it's remarkably profound. So in the United States, smoking causes about 480,000 early deaths per year. This is a tremendously high number. This is higher than the actual deaths that we see with any other substance and most other causes. And this is just daily looking at the data, looking at the dailies. This is disability-associated life years, and it looks at different types of behaviors that impact health. And it includes things from high body mass to alcohol use to being sedentary. And what you can see here is that tobacco use is #1 across the country and #1 in most states. So we still have a significant problem when it comes to smoking and smoking cessation, and it really is worth, investing our time and effort to do more for smoking. I also want to point out that the burden of smoking and the death and disability caused by smoking is highest in those who experience mental distress, who are enrolled in Medicaid, unemployed, have disability, low income, or less than high school education. And this is data from New York State, which I think it applies to most states. And this is looking at smoking levels of smoking by year, the percent of people in the population who smoke. And this is all adults. And as you can see, it's about 12 to 13%. And we look at frequent mental distress, the rates of smoking go up to about 30%. And the same is true with unemployment, disability, and having less than a high school education. So we really need to do more and focus on helping people stop smoking. And there are treatments that are available. We have at least 3 medications, 3 classes of medication that can help. This includes nicotine replacement therapy, varenicline, and bupropion. And this is just the data looking at quit rates with these different medications. So here we have people who receive the active drug looking across many different clinical trials compared to placebo. And as you can see, varenicline is the most effective when we look across studies. We have about 30% of people who stop smoking compared to only 10% on placebo. The data isn't quite as clear for bupropion. However, as I'll show you in a minute, when it comes to nicotine replacement, which is all these different groups of medications, gum patch, lozenge, spray, and inhaler, we get better quit rates when we combine these. Now, getting access to medication depends a lot on what state you live in. So some states provide comprehensive coverage. So for example, in New York State, where I live, you can call a hotline and anyone who smokes or a provider can help them get connected. They will help you get connected with care and you can get medications covered through your insurance. And so even though some of these items, for example, nicotine gum or patch are covered by insurance, oftentimes you can get these through a prescription and the person doesn't have to pay for the over-the-counter version. So, check with your state to see how much care can be provided. Even though some states don't have comprehensive coverage, they may still cover, for example, nicotine replacement therapy. And then there's also counseling available for smoking. This is from the CDC. This is a free line that's available across the country, 1-800-QUIT-NOW. This will put the person in contact with a smoking counselor who can be contacted by phone or by text at different times to help them feel motivated to quit. And then there's also, this is the texting program, Quit Now. And then there's also a free mobile app that you can download on a phone. This is a CDC app called Quit Start that also helps people track their tobacco use and try and feel motivated to stop smoking. So these are the treatments, as I mentioned, nicotine replacement therapy or varenicline and bupropion. The best use of nicotine replacement therapy is a combination. So this would be patch, which is long-acting, plus short-acting treatments. So the person puts on a patch, that way they have long-acting coverage over the day. They do need to take it off before bedtime so that they can sleep. And then you combine that with rescue for acute craving. So you can have a patch, for example, plus nicotine gum, where you chew a piece of gum when you're feeling craving for smoking. And data shows that this is more effective. The combination is more effective than using one product alone. Some of these products are available over the counter. That would be the patch, gum, and lozenge. Some of them require prescription. That's the inhaler shown here, and the nasal spray. So the inhaler, you inhale it through your mouth. Nasal spray goes in the nose. But as I mentioned, in some states, prescriptions will pay for patch, gum, or lozenge. And then we have varenicline. Varenicline used to be called Chantix. We don't have Chantix anymore, but varenicline is still available in the generic form. It's a partial agonist at the nicotine receptor, which means that it can block withdrawal and craving. It also blocks nicotine from binding. And I just want to point out that there was previously a black box warning from the FDA with respect to varenicline, saying that it caused neuropsychiatric side effects. That warning was removed in 2016, and we now have quite a quantity of data showing that there are no neuropsychiatric side effects with varenicline. This is why the FDA removed the black box warning, and there is no worsening of psychiatric symptoms. In fact, varenicline can be very effective in patients who have both depression and who smoke cigarettes. It can actually improve the depression and the smoking. And varenicline has been shown to be safe in patients with schizophrenia. And then varenicline may have a particularly helpful benefit when it comes to smokers who drink. There is data showing that varenicline can decrease both tobacco use and alcohol use in people who use both of these substances. Bupropion is an antidepressant. It's often called Wellbutrin. In general, the data shows it's less effective than combination nicotine replacement therapy or varenicline. That said, it can sometimes be better tolerated. Sometimes people are more willing to take it, more wanting to take it. So it definitely should be considered when we're considering pharmacology for smoking cessation. And I just want to point out, if you'd like more information, there is a free guideline from the ASAM website. You can download it. It's free. It discusses all of these medications, and it provides the dosing schedules, the side effects. It's really quite helpful. And the CDC also has a helpful tool that can be used not only by patients, but also by providers when treating tobacco use disorder. I want to talk just a little bit about the use of e-cigarettes for smoking cessation. I get asked this question a lot by smokers. And I'm just going to start with the CDC recommendations. Per the CDC, there is research suggesting that e-cigarettes use is associated with greater smoking. However, at the same time, there is data suggesting that people who are smoking cigarettes, who use e-cigarettes, may be able to decrease their smoking. E-cigarettes are not safe for young people, pregnant women, or adults who are not using tobacco. And according to the CDC, you really need to fully switch from cigarettes to e-cigarettes, meaning no cigarette use at all, in order to get the full benefit. At the same time, there's recent studies really showing, sort of like the benefits of e-cigarettes when it comes to smoking cessation. This was a large meta-analysis that was done relatively recently by the Cochrane Group. And it shows that, there's high certainty evidence that nicotine electronic cigarettes can increase quit rates compared to nicotine replacement therapy. In absolute terms, this translates into about 4 quitters per 100 people who are treated. And there's pretty good evidence suggesting that the adverse event rate, meaning e-cigarettes versus nicotine replacement, is about the same. However, I do want to point out that this data really only applies if people are using nicotine or e-cigarettes that they get that are regulated. If somebody's buying e-cigarettes online or from a source that doesn't have regulation, where it's not sort of regulated by the FDA with respect to the contents that it includes, the risk of having an unsafe product goes up significantly. So this really only approves to regulated products. And then there was a recent study that came out in 2024 that compared varenicline to nicotine-containing electronic cigarettes, and it showed that both were effective at helping people stop quitting the use of conventional cigarettes for up to 6 months. So that's just my 2 cents there on electronic cigarettes. So, and now I'm going to switch to alcohol use disorder. And I just want to start by clarifying the outcomes. So when we do clinical trials in alcohol use disorder, there are 2 different outcomes that we can look at. There's abstinence, where people stop drinking altogether. And then there's decrease in drinking, which is a decrease in the number of drinking days, percentage of heavy drinking days, drinks per day on drinking days, and relapse to heavy drinking. So in general, we can either have people obtain abstinence when they're drinking or decrease their drinking. And, heavy drinking is defined in research for women as 8 or more drinks per week, men as 15 or more, or binge drinking. And binge drinking is on 5+ days or more in the past 30 days would be considered heavy drinking. Binge drinking is also defined in women as 4 or more drinks on one occasion, and men as pretty much 5 or more drinks on one occasion. And I want to point out that we have significant treatments for alcohol use disorder. We have 3 FDA-approved medications. These are naltrexone, acamprosate, and disulfiram. And we have 3 evidence-based medications, gabapentin, topiramate, and baclofen. So these 3 medications, gabapentin, topiramate, and baclofen, even though they're not FDA-approved, evidence-based means we have enough data to show that these medications can be very helpful for treating alcohol use disorder, meaning that they can be prescribed off-label for this disorder. However, we have a problem, and the problem is that these medications are simply not used enough. So there was a recent study that looked at patients with alcohol use disorder and showed that 81% had received medical care in the past year. However, of these patients, only 12% were advised to reduce their drinking 5% were given information about treatment, and 6% received medication or received treatments. And this is just simply enough. We can't, we have these treatments that work for alcohol use disorder, yet only less than 10% of patients are getting these treatments, even though they're seeing healthcare providers. And this is where we really need greater intervention with respect to alcohol use disorder. So I just want to review briefly the data with naltrexone. This is an FDA-approved treatment for alcohol use disorder. It comes in two forms. There's the oral dosing, which is just pills. They come in 50 milligrams a day. Patients can be treated with 50 milligrams a day or up to 100 milligrams a day. And you can begin with low doses if needed. And then there's also a long-acting injectable that's given every 4 weeks. It's long-acting, depot injection, if you will, of naltrexone. And overall, the data shows interesting things about naltrexone. First, it shows that it reduces the intensity of the alcohol-related intoxication, higher euphoria, and can reduce craving. It can help with abstinence, and it can help with decreasing heavy drinking. Naltrexone can actually be used in two ways. It can be given on a daily basis, and people just take it every day and try to be more mindful of their drinking. But there's recent data suggesting that we can probably use targeted dosing for some patients. And this means that they only take naltrexone when they think they're going to need it. So we need to have patients who have an understanding of when they're likely to overdrink or drink too much or binge drink. So they may know that if it's a Friday and they're going out with friends after work, that they're likely to be binge drinking and they may want to take it on a Friday, or other situations where they're likely to drink heavily. It's definitely less studied compared to daily dosing, but it might improve compliance. Many people are not great about taking medications that they need to take every day, but they might take it when they think that they need it. And there are 3 studies showing that targeted naltrexone dosing can be helpful. There's one from 2001. This study was in actually participants who had severe alcohol use disorder, and it reduced relapse to heavy drinking. Then there was a study in 2009, and interestingly, this study was done in mild to moderate alcohol use disorder, not severe as a previous study. And it showed that there was definitely a reduction in drinks per day compared to placebo. And in men, targeted naltrexone dosing was more effective than daily naltrexone dosing. That was not seen in women, but it was seen in men. And then more recently, we have a study that was done in sexual gender minority men. They had mild to moderate alcohol use disorder, and they were binge drinking, which is important because we do see this a lot. And targeted naltrexone dosing reduced number of binge drinking days, and participants took it about 2.5 times a week. And also this study showed that patients were good about predicting when they needed to take it. They predicted about 70% of anticipated events, but it also shows there's room here for sort of behavioral modification or patient education, having people get better at predicting when they might need to take naltrexone if you're going to be using targeted naltrexone dosing. Gabapentin can also be used to treat alcohol use disorder. As I mentioned, it's not FDA approved. However, it is included in practice guidelines, including the APA practice guidelines, up-to-date, and ASAM guidelines. It's FDA approved for postherpetic neuralgia and epilepsy. And interestingly, the efficacy of gabapentin when it comes to heavy drinking seems to be better in people who experience withdrawal syndromes. And I just want to be clear here, what this study showed is we're not necessarily talking about people who have alcohol use disorder who have profound withdrawal syndromes, although that can be the case. This was people who had more mild withdrawal syndromes, such as irritability, anxiety, dysphoria, difficulty with concentration. And these often persist after initial abstinence, and naltrexone isn't really going to help much when it comes to withdrawal symptoms. So if somebody finds that they tend to be drinking more simply because they're feeling these mild withdrawal symptoms, they very likely will improve with gabapentin. And this is just data that was done in 2020 showing this. And over here, I just want to point out that they used what's called the Modified Alcohol Withdrawal Symptom Checklist. It's on a scale of 0 to 4, also downloadable online. And they looked at symptoms like nervousness, sweating, tremor, nausea. And here the data is showing that if they had these symptoms of withdrawal, even mild withdrawal, they did better on gabapentin compared to placebo. And they also did better compared to patients who didn't have withdrawal symptoms. Then there are additional treatments. I'm not going to spend a huge amount of time on these in the interest of time, but I'm going to go over them briefly. So camprosate, this was FDA approved in 2004 The oral dosing is 3 times a day, which can be sometimes problematic for patients, but some people are very motivated and will take it. It's not really clear how it works. The pharmacology of it isn't so clear, but it seems to balance GABA and glutamate, and it doesn't interact with opioids. So this can be an advantage for patients who simply can't take opioids can't take naltrexone because they're using opioids for other indications. And then there's also disulfiram. This has been FDA approved since the 50s. It blocks alcohol dehydrogenase, so this increases aldehyde levels in the bloodstream. And aldehyde causes all the adverse effects of alcohol, like nausea, flushing, sweating, and dizziness. It's often not used because of the adverse effects, so it really decreases alcohol use by the concern over the adverse effects. However, it can be an option for patients who are very motivated to obtain abstinence. Disulfiram can only be used to induce abstinence, not decrease in heavy drinking. For example, doctors, pilots, or train conductors, somebody who might have a lot to lose if they don't stop their drinking, might be a candidate for disulfiram. However, it does come with a black box warning. It can never be given without a person's knowledge. And the patient needs to know that they have to avoid all forms of alcohol, including sauces or mouthwash. And then additional medications are topiramate and baclofen. As I mentioned, these are not FDA approved, but they are evidence-based. And you can read more about these. There are 3 resources online that can provide information about treating alcohol use disorder with these medications. We have the APA practice guidelines, downloadable for free. We have the NIH website, NIAAA, also downloadable for free. And then at PCSS, which you can access by going to PCSS Now. This includes webinars and other resources where you can get credit, CME credit, and learn more about treating alcohol use disorder with these medications. All of these resources are for free because I'm a big fan of free things. Now I'm going to switch and talk about cannabis use disorder. Cannabis use disorder, let me just say, is on the rise. Cannabis is increasing in the United States. And patients who have psychiatric conditions are more likely to be using cannabis compared to people who aren't. And patients who have psychiatric disorders are more likely to develop a cannabis use disorder. So as cannabis rates go up across the United States, we have to be aware of the fact that our patients who have psychiatric disorders, are at a higher risk of developing a cannabis use disorder. And this is just data showing the odds ratio of having a psychiatric disorder and developing a cannabis use disorder in those who are using cannabis. And just across the board, all of these are increased risk. People who use any substance, who have any other substance use disorder, so they have an alcohol use disorder, they're much more likely to develop a cannabis use disorder. This is also the case with any personality disorder, mood disorders, and anxiety disorders. So part of treating patients with psychiatric disorders is also psychoeducation about the risk of cannabis use disorder because it's often minimized. Just a bit of notes on tolerance withdrawal and health problems when it comes to cannabis use disorder. Tolerance breaks have become very popular. So if your patient is doing a tolerance break, they likely have a cannabis use disorder and could use some psychoeducation on this. This is all over the web about how you can decrease your tolerance to cannabis so that you can get a better high down the road. But it's important to educate our patients that this is a sign of tolerance and a sign of a cannabis use disorder. When it comes to withdrawal, cannabis use disorder is associated with withdrawal. The symptoms include anxiety, irritability, fatigue, insomnia, nightmares. It can be subtle when it comes to withdrawal with cannabis use disorder. It's not as obvious as perhaps alcohol or opioids, and it's very long lasting. This just shows the time course of a cannabis use withdrawal. Here we have the acute effects lasting, starting within the first day or 2 and going on. And then this is followed by irritability, anxiety, and then anger and aggression. These symptoms can go on for out to 21 days. And when it comes to health problems with cannabis use disorder, we need to be aware of cannabis hyperemesis syndrome. So this is a syndrome where people have severe nausea and vomiting that occurs in a cyclical pattern. For reasons that we don't understand, it's relieved by taking hot baths or showers. It's mostly seen in males, although we're seeing it more in females. And the only solution is to stop using cannabis altogether. This is the data on the frequency of cannabis hyperemesis syndrome. And most people who develop the syndrome are using daily, although it is seen in people who are using weekly or less frequently. And it's also mostly seen in people who are using for significant periods of time, but not always. So most of the time we see cannabis hyperemesis syndrome in people who are using cannabis fairly regularly and chronically, but not always. And then there is a prodrome that we're hearing more about. So people might not have the actual outright syndrome of the severe nausea and vomiting, but what they can have is morning nausea, not necessarily with vomiting, but they feel a fear of vomiting, and it can come with abdominal pain and weight loss. So it's important to ask patients who are using cannabis about these symptoms. So let's talk about the treatments, the pharmacological treatments for cannabis use disorder. And what I'll say, just getting to the punchline, is that we don't really have good treatments for cannabis use disorder, which is why we have to be very mindful of the need to do more prevention when it comes to cannabis use disorder. And it's not for lack of trying. There's at least 25 randomized controlled trials, and a randomized controlled trial is a lot of work and a lot of money. And these studies so far don't really show a profound effect. So even though, I talk to a lot of young people in high schools, and I often hear, well, cannabis is safer than alcohol. I'm like, that's not necessarily the case if we're talking about a cannabis use disorder. I have more tools to treat an alcohol use disorder than I have right now for cannabis use disorder. So this is just a list of medications that have been studied and shown to have limited, if any, effect. There are some medications that can reduce withdrawal. These are listed here, such as mirtazapine, quetiapine, gabapentin, nabilone, and dronabinol, but they haven't been shown to really decrease use significantly or induce abstinence. There is some promising data in adolescents with cannabis use disorder. N-acetylcysteine and topiramate have been shown to decrease use or increase rates of abstinence, but this did not translate into studies with adults. So most of these clinical trials have looked at abstinence as an outcome measure. And so we've done a little bit of research looking at decrease in use. So just like with alcohol use disorder, we can decrease use. And the question is, can we at least decrease use when it comes to cannabis use disorder to a point where the person is better able to function? And this is just a reanalysis of some data that was done looking at it. What it showed is that these medications, quetiapine given at bedtime, dronabinol is synthetic THC, and lofexidine combined with dronabinol. And what this data showed is that people who were heavy users were able to become moderate users. And that's shown over here in this data compared to placebo. So this is the placebo group, this is the dronabinol group. And what we see is that heavy users are more likely to become moderate users. However, what this data did show across these different medications is that we didn't have an impact compared to placebo of moderate users becoming light users. So in summary, these medications might help heavy users decrease their use, but not necessarily to becoming a light user. And moderate users also didn't really decrease their use. That said, we really need more research when it comes to finding the benefits or how much of a decrease in use do we need to have somebody have a beneficial effect. And there was a study that just came out that's trying to look at how much of a decrease do we need to have benefit. And at this point, it's really not clear. It's somewhere probably within the range of 50 to 75% decrease in cannabis use to really have an improvement in quality of life when it comes to cannabis use disorder. And just cannabis use disorder, I want to talk briefly about the interaction with cannabis use disorder and suicide. Regular cannabis use, especially daily, is associated with an increase in the prevalence past year of suicidal thoughts, plans, and attempts. What this data shows over here in this graph is if somebody has cannabis use disorder and major depressive episode or major depressive disorder, their likelihood of having a suicidal ideation, plan, or attempt goes up significantly. If they have cannabis use disorder and not depression, they still have a higher risk compared to those who don't have a cannabis use disorder. So cannabis use disorder on its own can increase the risk of suicidal ideation and attempts. Combined with major depression, that risk increases significantly. However, I just also want to be clear, this isn't just related to cannabis use disorder. We see this same association with other types of substance use disorder as well. And this is looking at this is looking at this probability of a suicidal ideation here. On this axis, this is people who have no diagnosis. Here we have alcohol use disorder, cannabis use disorder, other drug use disorders, and depression. And where we see the biggest increase is when people have alcohol, cannabis, or other drug use disorders combined with depression. So it's just worth screening for suicide when we're talking to patients who have depression and or substance use disorder. And I just have one slide on cocaine use disorder. I just want to point out that we all know or we all hear a lot that there's no FDA-approved medication for cocaine use disorder. And while this is true, we do have evidence-based treatments. So we have data that can show that cocaine use disorder can be treated with pharmacology. There's data showing that bupropion can help with abstinence in cocaine and opioid use disorder. Topiramate, we have 3 randomized controlled trials that show that it increase rates of abstinence, and it should be considered as a medication in people who have comorbid alcohol use disorder. And then there's data showing that long-acting amphetamines can be helpful. These are prescription amphetamines, can be helpful in helping patients obtain abstinence. And this data is from a recent meta-analysis, and what it shows is that the helpfulness of different medications for cocaine use disorder. This is prescription amphetamines, and what the meta-analysis shows is that it favors psychostimulants. Modafinil still had a positive, and then this is the data with methylphenidate. And if you're interested in learning more about the management of stimulant use disorders, the ASAM AAAP practice guidelines are available for free online. You can download these, and we'll discuss all the data and the different pharmacological approaches to stimulant use disorder. I did focus here on cocaine use disorder, but the practice guideline does refer to methamphetamine use disorder as well. And just, the behavioral treatments for substance use disorders, in general, there are 4 that we use. The first is contingency management and community reinforcement approach. Contingency management means that we use positive rewards like vouchers or gift cards to incite people, to encourage people to abstain from drug use. And it's usually combined with community reinforcement approach, which focuses on positive influence, like support from the family, friends, or progress at work. Then we have motivational enhancement therapy. This is a therapy that helps patients identify their reasons, their ambivalence for addressing their substance use and the decision to pursue treatment. If you're interested in motivational enhancement therapy, there's a free manual online from the NIAAA that provides an entire guide about how to deliver this psychotherapy. Then CBT can be used for substance use disorders. It's used for other psychiatric disorders as well, but has been shown to be helpful for substance use disorders. It can help people, identify triggers for substance use and how they can mobilize resources that counteract these factors. And then there's also cognitive reappraisal, which is similar to CBT and has been shown to be helpful with substance use disorders. There's also more data showing that mindfulness can be helpful. This is awareness of the moment without sort of judgment or interpretation, sort of being mindful of different emotions and thoughts. Meta-analyses show that it can be helpful for substance use disorders. There are different types of mindfulness that are used to treat addiction. These include mindfulness-based cognitive therapy and relapse prevention. If you're interested in learning more about mindfulness, you can go to the OASIS website. This is a New York State site website, and it has trainings online. Now I'm just going to talk a little bit about TMS and some of the more recent research that's going on with substance use disorders. TMS uses an electrical coil that sits outside the brain, shown here, and it delivers, the electrical coil generates a magnetic field. That magnetic field goes through the skull, and it stimulates the brain underneath. And this is just an image of sort of the electrical field that's generated. Here, the brain is a sphere. And there are different types of coils that are used for TMS. There's a figure-8 coil shown here, and then there's the H coil. And what the H coil uses, there's different types of H coils, and they use different winding patterns to get different patterns of stimulation in the brain. And down here, I show 3 of them. We have the H1 coil here, which is FDA cleared for depression. We have the H7 coil shown here. This is FDA cleared for OCD. And the H4 coil, which is FDA cleared for smoking cessation. And this is just an example of showing the electrical field that's generated in the brain with an H coil. And as you can see, with the figure-8 coil, you have sort of a circumscribed area of stimulation in the brain. With the H coil, you get stimulation on both sides of the brain. It's bilateral, and it's more diffuse than the figure-8 coil. And this is just what TMS looks like. This is our research coordinator. This is one of our neurosurgeons. This is using the H coil. And essentially, with the figure-8 coil looks a bit more like this. The H coil is embedded in a helmet. You put the helmet on the person's head. We have to obtain the motor threshold, so we move the helmet over the motor strip, and we stimulate until we get movement, for example, the thumb flickering. And then once you have the motor threshold, you move the coil forward and you treat. Usually we treat at about 100% to 120% of motor threshold. And there are different types of TMS that we can use. So this is the frequency, how often we deliver the stimulation. It can be either low frequency, which is 1 hertz, or high frequency, which is 10 hertz. For the most part, clinically in psychiatric disorders, we use high frequency TMS stimulation. And this was a study that came out relatively recently using TMS for smoking cessation. This was a large pivotal study that led to FDA clearance for TMS for smoking cessation. It was a multi-site randomized, double-blind randomized controlled trial. It enrolled 222 smokers who met criteria for tobacco use disorder. They had at least one failed attempt to quit, and 68% of them had 3 failed quit attempts, and the study was 18 weeks. And this is the data looking at sham here in the white bars versus active TMS here, and this is the quit rate over here. And what we see, this is just looking at all participants. These are looking at people who completed. And what we see is that active TMS was more effective than sham when it came to increasing quit rates. However, I just want to point out that when we look at the quit rate here, we have about a 30% quit rate with TMS, which is the same quit rate that we had with varenicline that I showed you previously, or combination nicotine replacement therapy. So the next research that needs to happen is combining TMS with medication to see if we get a higher quit rate. Let's see if we can get an additive effect and break that ceiling of a 30% quit rate. And this is some preliminary study that was done in Canada. This is looking at the H4 coil. This is the one that's FDA cleared for smoking cessation, combined with varenicline. And they had active versus sham groups. Everyone was treated with varenicline. Some people got sham TMS, some people got active TMS, and they looked at the quit rates. And it was a small study, needs to be replicated and figured out, in larger studies. But they had a quit rate that was the same, sham and active, at week 4, but at week 12, they saw that the active group had an 80% quit rate that was no longer present at week 26. So this is very promising data looking at the combination of TMS and quit rates, but we need to move this along further. And I'm just going to move quickly because I'm running a little low on time, but this is just data looking at a meta-analysis of TMS for alcohol use disorder. All different types of TMS were combined in this meta-analysis, whether it's figure 8 coil or H coil. And what it showed is that TMS can reduce craving for alcohol versus sham, and that TMS can also reduce alcohol use. So far, studies have not really combined TMS with medications such as naltrexone, which would be the next step to see if we combine these two, can we get better quit rates? And just briefly, there's a little bit of research going on these days looking at ketamine for substance use disorder. These are, promising trials. These are not large multi-site trials, but just overall, like there are 3 randomized controlled trials that show that ketamine can be helpful when it comes to reducing alcohol and alcohol intake and alcohol use disorder. There are 2 randomized controlled trials in cocaine use disorder using ketamine. And there's one small open label proof of concept trial. This was not placebo controlled for cannabis use disorder. So if you're interested in studies using ketamine for substance use disorders, stay tuned. There's more research going on in this field, and so far it looks promising. And then there's a study that was done recently looking at psilocybin for alcohol use disorder. This was done at NYU. This combines psilocybin to diphenhydramine, also known as Benadryl. It was a randomized controlled trial. Everyone received 2 interventions, 2 psilocybin sessions or 2 diphenhydramine sessions, and they looked at heavy drinking. And overall, what the data showed is that if you look at the participants who received psilocybin here in blue versus diphenhydramine in gray, there was a decrease in heavy drinking days, percent drinking days, and drinks per day. And so just in summary, I want to remind everyone, that when we talk about substance use, we have social use, which can evolve into mild substance use disorder, moderate or severe substance use disorder. It doesn't always. Some people stay in the substance use, the social use realm. Some people will progress to mild substance use disorder. And from there, people may go on to moderate or severe. And I just want to be mindful of the fact that we need to focus more on the mild substance use disorder because patients and the general public don't really recognize the symptoms or recognize a mild substance use disorder. And early detection and treatment of substance use disorders can have a profound impact. It's important to recognize that many patients want to decrease their use rather than quit, and we need to meet patients where they are. And that's okay to start with a decrease in use. And just, my last point is that patients who have psychiatric disorders, whether it's ADHD, depression, anxiety, are more likely to develop a substance use disorder. And these are just a number of free resources that I mentioned previously. And this is just my thank you slide. This is the lab. I do want to point out, this is my fellow, Cesar Imperio. We have a publication that just came out. Everything that I've talked about in this webinar so far, I've provided free resources, but this is all in this recent article in the American Journal of Psychiatry. If you don't have access to it, just please email me and let me know. And with that, I want to thank everyone, and I'd be happy to take any questions.
Thank you so much, Dr. Martinez. So we did have some questions in the chat that I'm happy to answer in the order that they were received. Eric asked, when people are on a drug break, are there any individual difference variables that predict the drug that it might substitute?
That's a good question. I mean, yeah, when people take drug breaks, if you look, especially with cannabis, any website you go to talks about a tea break and how how you can reduce your tolerance. They don't really talk about the risks of that. And usually what I've seen is that alcohol substitutes. Because alcohol is also sedating like cannabis. People have insomnia, so they can't sleep. So alcohol actually worsens insomnia. It helps people fall asleep, but then they wake up in the middle of the night. So what I've seen for the most part is alcohol. I would not be surprised if people try other substances instead, like perhaps GHB or other drugs. But if we're talking about what's easily accessible, it's usually going to be alcohol.
Yeah, I think that's something that you see now with some of the designer substances that are not yet regulated as well too, like that opioid analog that's sold basically at gas stations as well
Mhm.
for withdrawal relief. I forget what that's, Kratom or something of that nature. So do you think it is availability that might have the largest impact?
So, and familiarity, many people have, even if they might be settled on cannabis, they might have experimented with other things. So access is definitely one, but also familiarity. If you're familiar with it, it's often used as a substitute.
Okay.
Mm.
Another attendee asks regarding the e-cigarette research, would the goal be to reduce and stop e-cigarette use over time if the person was using those to stop smoking cigarettes?
Right. So, actually in the UK and New Zealand, e-cigarettes are used as smoking cessation aids. We don't really use them in the United States. But if, as I mentioned, if we're using regulated, FDA regulated product, and you switch from regular cigarettes to FDA regulated e-cigarettes, you decrease the risk significantly, because e-cigarettes aren't going to cause, for example, heart disease, lung disease, emphysema. The risk is, nicotine doesn't vaporize by itself. And so you have to add things to it to get that to happen. And the real problem with e-cigarettes is, what are those additives? So if you're buying e-cigarettes from an unregulated source like online or something, you run the risk of having additives that you're breathing in and inhaling that can be harmful. But if we're talking about, e-cigarettes that are safe, if you can get somebody off tobacco onto e-cigarettes, that's the first step. And then from there, I wouldn't rush it, but I also wouldn't say, stick with e-cigarettes the rest of your life. You definitely want to try and go, if you can, from e-cigarettes to perhaps medication, Varenicline or NRT, or wean the e-cigarettes. So that would be the ideal use, at least in my mind, of when it comes to e-cigarettes.
Is it perhaps the behavior substitution with the e-cigarette then that would be kind of the most attractive or the mechanism that would make it more effective than, say, switching to gum or a patch or something?
And there is now the nicotine inhaler. It is, it requires a prescription, but as I mentioned, you can get it in most days. I think, just talking to smokers, it seems like having that inhaled nicotine is a thing that really helps them get off cigarettes faster. So I've had a lot of success with a nicotine inhaler. I try to combine it with a patch if people are going for nicotine replacement. And that's, I think, the first step is getting off tobacco and using that as a stepping stone, but then, trying to get off e-cigarettes altogether. But people can take nicotine replacement products for a long period of time. Just to be clear, nicotine does not cause heart disease. It doesn't cause impaired wound healing, doesn't cause cancer. So if you need to have your patient on a nicotine patch for a long period of time to stop them from smoking, then that is what we need to do. Just like,
Okay.
opioid use disorder, we put them on methadone for a long period of time. We need to be doing that as well.
So Ali asks, are there neurobiological differences between different types of addiction, and or do they follow a similar pathophysiology in the brain?
We don't really know the answer to that question. I mean, I ask myself that question all the time, like why when I see a patient, why alcohol? Why not, why not cannabis? And we don't really have a good answer when it comes to the neurobiology. However, we have a bit more of an answer when it comes to psychiatric comorbidity. So, for example, we have data showing that about half of patients who have cannabis use disorder have ADHD. That's a profound interaction. And that's a whole nother talk in itself, ADHD, because that's what I see all the time. Patients come to me, they have a cannabis use disorder or a tobacco use disorder, and the likelihood that they have ADHD is incredibly high, usually untreated and undiagnosed. When it comes to alcohol, mostly what I see, depression, anxiety, PTSD. So, I don't think we have the neuroscience of it, but we can be mindful of is that when our patients have psychiatric disorders, they're much more likely to be using substances and much more likely to develop a substance use disorder. And if
Yeah,
they
I
have
think with
both, sorry, and if they have both, we need to treat both at the same time.
Yeah, I don't envy you in that treatment realm because I feel like that there are a lot of complications there. Just thinking of ADHD, and the efficacy of stimulants on, people who have used cannabis for a long time, those can decrease as well. So I can see how that dual diagnosis, dual therapy would be incredibly challenging. So Eric asks, several medications are used across drug classes. Is there any evidence that these medications have better or worse efficacy in polydrug using people?
That is a very good question. We really lack data in polydrug use. And we definitely need more. However, we are doing more research, for example, varenicline, and people who use alcohol and tobacco tend to do pretty well on varenicline with addressing both substances. So that research is coming out more now, and and definitely, keep an eye out for it. So
Wonderful, thank you. Ken asks, in terms of some of the TMS data that you presented, I believe he's referring to the TMS for smoking cessation and the abstinence figure. Do these data suggest that it doesn't have a long-term effect on sustaining quit rates? I think he's referring to your figure where at, what was it, 24 weeks, the abstinence rates seem to drop.
right. So the original study was just TMS alone, and it showed that quit rates remained at about 30% at 12 weeks out. Beyond that, we don't really know. The study that I showed you where the quit rate sort of came and went, that was a small study that was done combining TMS with varenicline. And what we really need in that study is a follow-up study with a much larger N. So that study had a small number of patients, and it was sort of a promising effect, but we need to continue that. When it comes to using TMS as a treatment, I think that when we use it to treat substance use disorders, it's going to be similar to depression. So we use TMS to treat depression. What we do is we use it and we sort of, get people, we usually use TMS in people who don't respond to antidepressants. Then we kind of get them out of the hole, if you will, of depression, and then use pharmacology to keep them going. And that's what I think the real effect will be with TMS. Is like, with smoking cessation, we really need to combine it with medication. And with alcohol, we have promising effects with TMS and alcohol, but what we need to do is, TMS when you have the patient who's just presenting to treatment, and then add medication as we go on to try and keep them better.
Wonderful. So maybe an initial sort of motivational enhancement, so to speak, with TMS to kind of get them oriented to therapies, and maybe it has better acute effects. Is that what I'm hearing? And then,
Think of it kind of like ECT for depression, right? It's like we get
mhm,
people better, and then they're able to respond to our traditional treatments.
okay. An attendee asks, do you have any hints for getting clinicians to, or for helping clinicians be more capable of obtaining honesty from, let's say, a reticent patient?
Yes, great question. That is an excellent question. And what I can tell you is, people go to their doctor and either they're asked in person or sometimes they're just asked on the form, like, do you smoke? Everybody says no. There's data in this country showing that the number, if you look at the number of cigarette sales compared to the people who say they smoke, there's no way that number of people can be smoking all these cigarettes. Same is true with alcohol. We have to change the way we talk about it. We can't just say, do you drink? How much do you drink? It needs to be part of just the health conversation. And it really needs to be presented in a way that's sort of non-judgmental. So, I mean, when I see people that are coming for substance use disorders, but, in our research studies, if I'm talking to healthy controls, I don't start with, do you drink or do you smoke? Because everybody's going to say no. I start with other health questions. And then I bring in, stress often comes along with smoking or alcohol. Smoking is great at reducing stress. That's not in question. The question is, has it ever been a problem for you? I try to ask questions more in that way. I always
So,
start with drugs and then move to the illegal ones.
so sort of getting them to maybe open up on
Yeah,
other items and probably related symptoms first, and then asking the direct question about, do you smoke or do you use cannabis or something like that?
right. And it's always better to be, how much? How much do you drink? Right.
Yeah. Oh, okay. How much? So not
Rather
necessarily
than do you
asking, do
drink? How
you
much
drink?
do
How
you
much?
drink? Right.
Okay. Wonderful. Thank you.
And if you start
Uh,
with that and then go to the other drugs, it doesn't sound as weird. If somebody walks in, you're like, how much cocaine do you use? It comes off weird. But if you start with, how much do you drink? And then you just use that same question to ask about other substances, it just fits in sort of like your medical history.
Oh, that seems like that would be incredibly effective. So an attendee asked about using semaglutide, Ozempic, the GLP-1 inhibitors in treating AUD or other substance-related disorders. Do you
Interesting.
have any thoughts on those or?
I do. I took that slide out because I was running out of time. So, one of the interesting questions that came with, Ozempic and forgot the names of the other drugs, is, will people drink more? It was a concern because we do have data with people who undergo bypass surgery or that, there was an increased risk of alcohol use disorder. So right now, there are no studies looking specifically at, Ozempic versus placebo and alcohol drinking. There are no results. There are studies going on. There is research looking at large databases of patients and showing that if they take these medications, these GLP agonists, that they don't increase their alcohol use and some will actually decrease their alcohol use. So that is, yet to be seen. With respect to other substances, there's maybe research going on, but I don't know of anything published at this point.
Thank you. We have time for one more quick question. Isabel is asking about sex effects. Are there certain treatments that might work better for males or females?
We don't have really great data specifying whether or not treatments for substance use disorder work specifically better for males or females. There are some hints here and there. But what is important when we're talking about sex differences is, as I mentioned, many patients have a psychiatric comorbidity. And the data says we have to treat both at the same time. So women are much more likely to have depression and alcohol use disorder. Men may be more likely to have PTSD and alcohol use disorder. And what's going to be important is not only treat the alcohol use disorder, but to treat that disorder as well. So if we're talking about differences between men and women, it's really important to look at across all patients, look at the underlying psychiatric disorder that may be accompanying a substance use disorder.
Thank you. Thank you so much. So we are at time. So I want to close by thanking you again, Dr. Martinez. And I want to send a thank you to our audience for joining us today. And we have a fantastic day ahead. So I hope to see you all, and I hope you will join me throughout the upcoming sessions. Thank you.
Thank you.